I am so excited. We have a new presenter on our webinar series, and I could not be more excited about having him on our webinar series. Um, Seriously, has an incredible background when it comes to personal injury. Um, he's been a guest instructor at professional conferences, state association events, professional schools, been published in several national journals, so you may have heard his name before. He has um, a background with personal injury patient care, case management, clinical documentation, risk management, proper coding, compliance, profitability. I mean, it goes on and on and on. And well, all of those are words that speak to my little soul because I am all about making you guys successful. He is a diplomat of the American Board of Chiropractic Orthopedics and a certified professional coder with the American Academy of Professional Coders. And if I do say so myself, that is not a test for the faint of heart. They give you 5.5 hours to do it, and it's still not enough time to get it done. But anyway, he's also served as an expert witness for both plaintiff and defense cases and has been an independent chiropractic consultant for automobile insurance carriers, healthcare companies, and state regulatory agencies. So I am very pleased to introduce the Dr. Scott Tauber here, who is going to talk to us about the 3 most costly mistakes to avoid on the initial PI visit. So thank you so much, Dr. Scott, for being here.
Okay. All right. Thank you. Thank you. And hello, everyone.
Oh, I apparently got a little excited and advanced your slides for you, so let me fix that.
Thank you. Okay. Hello, everyone. Welcome to the webinar, and thank you for taking time out of your busy practices to view this presentation. This is 3 costly mistakes to avoid on the initial PI visit. And I want to thank ChiroHealth for hosting this and Christy for her help in putting this all together and making it a nice, smooth transition. And as she mentioned, my name is Scott Tauber, and I am the COO and Director of Education at the American Institute of Personal Injury Physicians, and I'll be taking you through this presentation. So you know how some providers find personal injury confusing, aggravating, and frustrating, and there might be others that I like to find personal injury or call it the part of their practice that they love to hate. Well, whether you fall into one of those groups or not, providers can make many unintentional mistakes right at the very beginning of their cases. And today I want to share with you 3 common and costly mistakes that providers make on the first visit. Hopefully you're not making these, and this is a refresher. I'll share why I consider them costly and what you can do about correcting them. The first visit in PI is extremely important. I would call it crucial. And there's literally a laundry list of mistakes that can and are made regularly. I mean, we can pick all kinds of mistakes from these 5 categories, which over the years I've identified where providers can make these mistakes in your procedures, your new PI patient procedures, even before they get to the office, your PI specific policies, clearly in your documentation and management. There's a whole host of issues and mistakes that can be made there, and in the billing and coding department as well. Now, in this presentation, the mistakes were chosen not only because they're common and costly, but they can easily be remedied as well, which is important once you become aware that these are actually issues in your PI cases. Now, when I say costly, many think of money right away, and you'd be right. And there's a big reason to correct that. Money is a big reason. Lost revenue, revenue potential, future business are all reasons why you should consider identifying and correcting these mistakes, but also consider non-compliance. or patient complaints. Patients can complain to regulatory agencies, state boards, and then that can become costly for providers as well. Or, in fact, insurance carriers themselves can file complaints or file complaints to regulatory boards or make your life difficult. So common and costly can refer to potential patient referrals, whether it's PI attorneys, if you're not getting referrals from attorneys as many as you think you should or you would like, there's a reason for that. Compliance versus complaints. Non-payment of your charges, if your insurance carriers are not paying you or they're giving you a hard time or they're sending your cases for records reviews or IMEs, and reduction requests from PI attorneys or representing attorneys. In general, costly encompasses time, the effort that it costs to overcome some of these issues once they occur, and of course, the money aspect as well. Now, before we get into the actual content, quickly here, I just want to cover what I like to call some basic facts about personal injury to kind of give everybody just some equal footing and kind of give you an idea of where we're coming from and why sometimes personal injury can be that part of your practice that I talked about just a minute ago. Personal injury is really a subspecialty for nearly all of the providers out there. Now, of course, there's offices that do 100% personal injury, and this presentation is certainly not about making you a 100% personal injury practice, but it's a subspecialty for nearly all providers. You do a lot of things in your office. You're seeing PI, you're also seeing wellness, you're seeing private pay, you're seeing health insurance, maybe you have nutrition, maybe you have a special modality. You've got a lot of things going on, and PI is only one slice. And so you're mainly family, what I call family providers. The other fact is most of us were not taught personal injury in school. If you were taught it, it was very rudimentary. And in fact, if you graduated more than 5 years ago, the information that you learned is already outdated. So if you haven't been keeping up, and that's that last line right there, you must keep up. It's that part of your practice that's constantly changing. So it's so important that you keep up. Otherwise, you'll find yourself quickly falling behind. Now, one last thing, and I kind of have to bring this up because this is one of the justifications that somehow providers like to share with me or tell me when they meet me is like, you know what, Scott, I don't do a lot of PI, so I don't really need to know this stuff, do I? Or I don't really need to do this, right? Well, the reality is, yes, you do need to understand and you need to do this. If you accept any PI cases, you need to do this and you need to be aware of it and correct these mistakes. Even if you, say, only see one PI patient a month, you still leave yourself vulnerable and liable and accept the inherent risk, not only that we're going to discuss in this presentation, but in personal injury in general. So just because you may not see a lot of PI doesn't absolve you from doing it correctly, because I'm sure you're aware PI cases are highly scrutinized. And in fact, it's the only time that you have to send in your notes and your bills and records for scrutiny in order to get payment. It's one of the few things that you are required to do. And that leaves yourself vulnerable. So we want to correct some of these mistakes. All right. One quick last thing here. I know I said the last one was the last thing, but I want you to think about being proactive in personal injury. Even if you do just a small amount, when a PI patient calls, it's always easier at the start to do some of these things. And that's why we're focusing on the first office visit here. It gets more and more difficult to gather information, to get your patient to comply with certain requests as the case goes on. And it's certainly almost impossible or extremely difficult after the patient is released. So while you're at the beginning and while you have access to the patient, we'd like you to begin being proactive in these steps that we're going to discuss right now. All right. So mistake number one is not obtaining the pre-accident medical records. Now, most providers know about getting post-accident medical records. I mean, that's something that should be commonplace in your office. Patient comes in, if they've been to the emergency room, if they've been to urgent care, if they've been to any providers prior to coming to your office, those records, most providers are making an effort to get those. But that's not what we're talking about here. We're talking about pre-accident medical records. And this is very different, and I will share with you that a large percentage of providers make no effort. First of all, that they're not aware that the importance of this, and I will share this with you in the next few slides on why it's important and costly as well. But they make no effort, so they don't even bother. So the large portion of providers are not even aware that this is something that they should be doing. It is required for a complete history. Now, we want to believe our patients. When we're doing our knee-to-knee initial PI history, we ask the patient, Mrs. Jones, have you ever had headaches and neck pain before? Have you ever been involved in a motor vehicle accident before? Oh, no, no, never, never. Have you ever had the similar symptoms? Oh, no, never. And so most providers stop right there. We want to believe our patient. Unfortunately, I think if you've been in practice any length of time, you know sometimes your patients have selective memory. Or maybe they just plain old forget because they forgot what their history is. But we can't stop there in PI. So in order to get a complete and accurate history and to improve our veracity of our records, we want to make an attempt to get pre-accident medical records. Now, this requires a process, and once we get them, it's important that we actually look at them, but let's at least identify this is something that we need to do, and let's take these following steps here to go ahead and do them. So, pre-accident medical records, right? Why are we talking about pre-accident medical records? Well, number one, it supports your causation statement. In order to place a causation statement, which should be in every single one of your PI records, a causation statement that's not based on supposition, opinion, or just because, we need those pre-accident medical records. So if you're a provider out there now listening and you're going, well, I put causation statements into my records. Fantastic. The next question I would have, are you getting the pre-accident medical records? Because if you're not, your causation statement is inaccurate. It can't be. So it can't be accurate until you get all that information. So first of all, causation statements, and then making sure that they're strong causation statements as well. Next is you don't want to get blindsided down the road. If you don't get these records, you're going to know less about your own patient than other people will. For example, records reviewers, insurance carrier adjusters, possibly an IME doc. Now, two of those that I just mentioned will never even see your patient physically, but if they get the pre-accident medical records and you don't, they actually know more about your patient than you do. And if you ever wind up in a deposition, you will be blindsided because the defense is going to get those records. Now, hopefully you don't get a lot of depositions, but there's always a possibility in a legal environment, right? And then third, it improves your marketability. You're probably going, how did getting pre-accident medical records improve my marketability, especially with PI attorneys? Well, you can absolutely use this process when you're marketing to PI attorneys. You're sitting across from them. One of the things that you can discuss in your meetings is pre-accident medical records. You're going to get them, and you're going to supply them to the attorney at no cost. And I'll show you how to do that here in just a second. But what this does, and why I mentioned that it improves your marketability, it shows that you understand PI. It shows that you can appreciate what the attorney needs or what needs to be done on cases. It shows you understand the nuance of personal injury. And certainly attorneys want to work with providers that understand and are team players in their cases. And this is subtle. It saves you time, effort, and money, and same with the attorney as well. I'll expand on this in just a second. But also note that there should be at least 3 entities that are attempting to get these pre-accident medical records. One would be the representing attorney themselves. Number 2 would be the adverse or the at-fault insurance carrier. If you've ever been in a motor vehicle accident, you typically get a letter from the carrier, from that carrier, right? Not your own, asking for the names and information about the providers that you've seen in the last 5 years. And then you should be the third one attempting to get these records. So far we've got a lot of things going on why these pre-accident medical records are extremely important. Now, how do we do this? Well, the first thing you need to do is you need to create a document in your office, and make sure that when you're creating it, you're asking the patient for all the information, the previous providers and health history. You can see an example here of one that our clients use, and it's actually over here on the right. You can see it's a 2-page document. It's very thorough. And we ask the patient to complete this either before they come in or when they come in, depending on how much paperwork you want to bombard them with, right? PI is known for paperwork, but be aware that you're looking for accuracy, so you want to make sure that you don't bombard the patient and they rush through this, but create a document that goes through the patient's history, and then they can fill it out either before or when they come in. Have them sign it as an attestation that it's accurate. And also, if you're asking certain questions, keep an eye out for any blanks. Make sure that there's no blanks. We want to hold our patient accountable. We want to put the burden onto them that they need to tell us, and they need to be accurate about their history. So create that document, make sure that they sign it, and train your staff when they give it back that there's no blanks. Either put an NA or a none, but we don't want to see any blanks. That's step number 1 in your office. And this is done by your staff. So if you're the provider and you're going, oh my God, this is going to take forever, these are things that you're going to delegate, but you need to oversee and understand the importance and make sure that you hold your staff accountable. Next, go ahead and send out that request, your staff, immediately. And you can see this is a fairly recent one here on August 2nd. A client went and sent these out, and then go ahead and follow up every 2 weeks. Create a calendar. Have your staff create a calendar on their computer, or a paper calendar, or some way that they remind themselves, did I get those records? Did we get all those records that I sent out? And if not, then we need to contact the providers again. The last thing here is to bring this form to the weekly staff meeting so your staff can review it with you, and you can keep on top of their efforts to obtain these records. Now, if you're not having staff meetings, I get it, because staff meetings can quickly go sideways. But I would highly recommend you have, and what I recommend to our clients is a PI-specific staff meetings, just your PI cases, and discuss what's going on. This could be as short as 10 minutes. Doesn't need to be an hour. But have a staff meeting, and this is something that you could bring to your staff meetings so everybody is aware of what's going on, especially you as the provider, and you make sure that these are getting accomplished, your staff is being held accountable, and nothing is going for more than a week or 2 without you knowing about it. One of the worst things that can happen is something is all of a sudden 3 or 4 months down the road and you realize it wasn't done, and now you need that, or the information is not there, or something wasn't done, and now it becomes a problem. PI cases are valuable. So don't let these things go. I mean, these cases are not $25 and $35 copays. These cases add up to thousands and thousands of dollars, and when they go sideways or bad, it becomes painful and costly, and hence the name of the webinar. Now, it's costly in a lot of different ways, these pre-accident medical records. You can see here in my example that the cost for obtaining medical records in this disbursement sheet from an actual attorney is zero, because in this particular case, the provider obtained the pre-accident medical records and gave them to the attorney, so they didn't have any cost. You and I know that when we get a records request for patients from another healthcare provider, we make copies and we send it out, and there's absolutely no charge, right? Provider to provider, not an issue. But guess what? The minute we get a request from somebody other than that, and an attorney, oh my God, $50, $100, $200, $300, okay, that can quickly add up, especially if your patient has a complicated medical history. And you can see there, it's not uncommon for attorney costs to be $500 to $2,000 just to obtain medical records. And this is something that comes right off the top. It's settlement, and it decreases the disbursement. So you don't get charged. You save the attorney time, effort, and money, and you create what's called a bigger pie, where possibly if you're participating in the settlement and your bill is going to be paid from that, wouldn't you want more available rather than less? The answer would be yes. And so these are things that also make you marketable. So this is the reason why pre-accident medical records, I mean, we covered at least 5 or 6 different things just on this one mistake alone, but create the process and keep track of it, and then you can save time, effort, and money, and also protect yourself as well down the road. So if you get these, supply them to the attorney, and you're going to make yourself more marketable. You allow for more at the end, which may avoid a reduction request also. So if you're getting reduction requests, this is a way to help out on that. All right, cool, right? Mistake number 2. Now, this comes from your examination procedures. And here's just a little formula that I like, and this is in general from your exam, is identify, or be aware that something's important. Identify, examine, document, and differentially diagnose. First, let me say, take your time during your initial examination. This is not the time to rush or to cut your exam short because you got a private pay patient that's maybe waiting another minute or two than they normally wait. And so providers kind of get a little bit antsy. They run out of the room of an acute traumatically injured patient to go see a wellness or private pay patient that maybe has to wait another minute or two. Which one has greater liability, A or B? Right? That's a pretty simple question. Take your time and follow this particular process of identify, examine, document, and differentially diagnose. Now, the one injury and condition I want to focus on from your examination is TBI, because it's often overlooked and sometimes it's even avoided. And this can be costly in so many ways. It could be costly for a failure to diagnose for you. It could be costly because your patient can't get care, treatment, or management for it unless it's documented, or at least follow that formula that I just shared with you. And it's costly from a settlement process. So if you'd like to increase your liability and risk, then just ignore this. But if you're truly trying to decrease and mitigate it, make sure you're looking for TBI and then do a good job of trying to at least document it. Now, the TBI, there's a lot of different definitions out there. They all seem to have several things in common. But a traumatic brain injury is is described as a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head. Now, at the bottom there, statistics estimate between 50 to 70% of TBIs are the result of a motor vehicle crash, which means half to almost 3/4 of the patients that come in to see you could potentially have a TBI. Now, as healthcare providers, and as the first person to possibly see this patient after their motor vehicle injury, you have a lot of liability there, and you want to at least identify this and then follow that process that we gave you a couple slides ago. Let's take a look at some of the potential symptoms. Now, these are not all the symptoms that a TBI can present as, but headaches, dizziness, concentration, blurred vision, visual disturbance, lethargy, sleep disturbance, memory, ringing, buzzing in the ears are all very common. And you know what a lot of these also have in common? Is these are value drivers. When it comes to the evaluation software, now I don't want to get too far off track here, but I'll just give you this. When it comes to the evaluation software, value drivers increase the value of a claim, hence they're called value drivers, when they're documented correctly. So if we ignore them or we don't do a good job working these symptoms up, not all of them, but a lot of them here are value drivers. If we don't do a good job, it can actually cost us money, cost the claim to be diminished. And that's obviously something that could potentially then go ahead and cost you referrals, relationships with attorneys, patients, all that. Let's take a look at some real life examples here. I put in a couple. Now, this is an actual patient. When you take a look at these symptoms here, about 1/3 of these symptoms are related to or can be related to TBI: headaches, sleeping, depression, anxiety, fainting, buzzing, dizziness, in addition to everything else. So sometimes our patients really give it to us on a silver platter. And I would argue that this is a very common example. If you look back at your last, I don't know, half dozen PI cases, say, go back and take a look at the intake form and see what they wrote down. I would argue that you're going to see a lot of commonality between your patients and this example right here, especially when it comes to the potential TBI symptoms. Here's another example: headache, sleep disruption, blurred vision, ears ring, dizziness, in addition to all the other ones. So this one may be about 25% of the accident-related symptoms could be tied in with TBI. So this is the first step, is to be aware. Take a look at the intake forms. The next step is to examine, and there's a whole host of things that you can do. So some tests to consider: mental status, cognitive, obviously your regular sensory motor and neurological examination. You can use questionnaires. You can use diagnostic imaging as well. These are all things that you can use. But the big mistake is ignoring it, or in fact hoping it goes away so you don't have to do anything about TBI or their symptoms. And I know some of you out there probably already know that there's studies that will say, TBI symptoms will resolve themselves over time, over sometimes few days, sometimes few weeks or months. But here's my question. There's also studies out there that say that there's a good 20 to 30% that are not going to resolve. So are you going to be that provider that are just going to hope that they go away, or quote unquote, providers have told me when I look at their records, well, I'm just monitoring the TBI symptoms, when in fact the records really don't reflect that. Next thing you know, you're 3-4 months down the road and the symptoms haven't resolved and the patient is still having these issues. And now what do you do? And who's liable? Well, that would be you if you haven't gone ahead and identified it and followed the formula. So examine it, get it documented. I'll show you an example here in just a second on why this is important. Now, have these at the ready. This is another way that you can document and identify TBI. There's a ton of outcome assessments that you can use, and this is one obviously is for concussion. This is as simple as handing it to the patient. Keep it simple, keep it standardized, and do it consistently. Once this patient fills it out, your staff gets it back, they make sure that it's been completed accurately, thoroughly, make sure that it's signed. Your job is to review it and get it into the records. It's a very simple process so far, right? We're aware, we identify, we examine, we document, and then we try and differentially diagnose. Now, here is an example of diagnosing and simply getting it into the records so it can be used later on by those that are attempting to settle the case. So here we have a patient in our first example. The neurological shows dizziness, and the doctor went ahead and diagnosed it. Okay, that's good. That's a start. Now, for those of you that are thinking, do I need to actually come up with a diagnosis of TBI or concussion? My suggestion is you don't have to put the name on it. Get the symptoms in there as a good start so they could be used later on, but follow the process. Here's another example. This one, unfortunately, not as good. As we can see under the underline is dizziness, headaches, difficulty sleeping, but when we come further down into the records, none of that, other than the headache, the R51, is diagnosed. That is a problem later on. Now, we as clinicians don't see this as being costly, but it can be costly when it comes time for settlement. It also can be costly because your patient can't get the care and management that they need as well. Let's take a look at this example. A $1.52 million binding arbitration verdict for mild brain injury sustained during low-speed collision. Now, I will grant you that there are a lot of things that have to go right and be in place for this amount and this type of settlement. But I can tell you this, there'd be no chance of this unless it started with early and thorough documentation. And of course, let's just say that the first visit would probably be a good place to start with that, right? Also, keep in mind every symptom, whether you plan on treating it or not. You already know some symptoms, right, in PI maybe are a little bit outside of our scope, depending on what your scope of practice is in your specific state. But they all have value. So whether you plan on treating them or not, it's important that they get documented. There's plenty of providers out there that only document the symptoms and conditions that they really like or they think that they can help, and that's costly. So everything has value, and when you get it into the records, as I just showed you, it allows your patient to get care and management and treatment. You may not treat TBI. You may not want to treat it. You may want to do nothing other than document it. And there may be some of you out there that have ways of treating it, but get it into the records. Don't deny your patient care and management by overlooking or avoiding these very common conditions and symptoms. And then mistake number 3, the final of our 3 costly mistakes, is home care. Now, it seems simplistic enough, right? Not giving it or not documenting correctly home care is a problem and a mistake, and it can be very costly. Now, first of all, you have many choices when it comes to home care, and I'm not going to tell you which ones to use. That's certainly going to be a case-by-case basis. You have a lot of choices, but what I'd like you to consider is giving home care to your patients before they leave the office on that first office visit. First of all, it's a multiplier for every single injury if it's documented correctly when it comes to the evaluation software. And it prevents what I like to call case killers, and I'll talk about that in the next slide or so. We have to anticipate these issues or these case killers, which can have a detrimental effect on the case if they're not resolved or they're not made to quote unquote go away. And I would suggest anticipating one of the most common case killers, and home care can help you with this. First of all, let's describe it. A case killer is an issue, a situation, or a problem that when present and not cleaned up or eliminated, usually through documentation, can decrease the value of a claim and potential settlement, and therefore would be a costly mistake for you in a lot of the ways that we have already described. Now, the one that I'm referring to is called gaps in care. We all would like to think that our patients, right, are going to be 100% compliant with their treatment plan the way you outline it. It's going to be 3 times a week for 4 weeks, and they're going to follow it to a T. Well, unfortunately, right, our patients don't necessarily follow that. Things come up, they forget, whatever the case may be. Sometimes there's gaps in care where patients are missing large stretches of care. Now, in PI, it's even more important that we be aware of this and anticipate it. We already know. On visit number 1, we should anticipate our patients are not going to be compliant, and that's why we're giving home care. Also because of what? It's the right thing to do, right? It helps to support their treatment, and it's a benefit away from the office, all of those things. But we want to anticipate the gaps in care. So home care and self-care, same, kind of fall in the same umbrella. It actually supports your treatment. So there's, in the eyes of the evaluation software, doing something away from the office has tremendous value because the patient is not relying necessarily on always going to the doctor and something always being charged. It helps to mitigate the actual costs or damages since the patient is helping in the process and not relying on the provider. It's going to help eliminate or avoid those case killers or those gaps in care, and especially with the correct documentation. But for right now, and I'll share with that with you in just a second, but for right now, let's just prescribe or recommend some form of home care on the initial visit before the patient gets out the door. All right, so that's the really important distinction is on that first office visit. Don't wait just in case, because you don't know if that gap is going to happen after the first office visit. We'd like to think the patient's coming back tomorrow or in 2 days for the report of findings and more treatment, but you don't know. And anticipating that and explaining to the patient the home care, the reason why, how to do it, and documenting it will be beneficial, because one gap in care or one case killer in an entire case, we might be able to overcome at the time of settlement, but 2 or more make it very, very, very difficult. So this is the way it's done. At the end of your first visit, either you or your staff, right? You make sure that you give it to them, make sure you explain it to them. If you can give it in writing, that's fantastic. If you can have the patient sign it, that's even better. Whatever you do, make sure that the patient completely understands what's going on. And here's an example of an actual case. Now, the provider here is on the right track, but unfortunately, if you look a little bit closer, well, let me back up for a second. There's 3 things that really need to be documented. So your documentation should include the type of home care, obviously, and let's just use ICE as our example, but it should also include the frequency and the duration. And that would be the same 3 requirements, the type, the frequency, and duration throughout the treatment plan. Anytime you're giving home care, that should be the 3 things at a minimum that you're documenting. So let's look at this example. The recommendations, the end of line number 1, she was instructed to apply ice to the lumbar regions every 2 to 4 hours for 20 minutes. The problem here is that we don't have a duration. We don't have the number of days or weeks that this provider is recommending. So it's falling a little bit short in getting to the evaluation software and helping, and it's going to be a little bit costly. And a copy of the signed instructions were filed in the patient's record. So that's always good. Written instructions and an acknowledgement are also important. All right, so the documentation component is just as important as giving the home care as well. All right, so we covered quite a bit here. And if anybody has any questions, I guess, Christy, now would be the time. If anyone's typed in any questions or you see any questions, I'll be more than happy to answer. We covered a lot of things here relatively quickly, but you let me know
Wonderful.
if there's anything coming in.
We do. We have one that says, do you recommend a particular previous providers and health history form?
Do I particular? No, I don't. Well, we have one that our clients use, but there's not really one that's out there that's a standard. So I would recommend creating what's comfortable for your office. But like I said, we have one that our clients use.
Okay, our next question, what can I do if my staff can't get copies of the pre-accident medical records?
Okay, that's a good question also. And sometimes you're going to make requests and the staff is just not going to be able to get the other providers to comply. What you want to try and do is get your patient involved. And this is why it's easier at the beginning, because if you wait 3 or 4 months, your patients are not going to be as motivated to do this for you. But explain to the patient why you need these. And your patient may need to call the providers, or if the providers are local, maybe they can stop by the office and actually pick up those records and bring them to you. But don't let this go. As a last resort, as I mentioned, the attorney is also trying to get those, but it kind of goes against, we're trying to get them and give them to the attorney. But if for some reason you're just totally stonewalled, just contact the attorney and get them from them, or let them make the effort if they haven't, because they're relying on you. So there's a little bit of variation there, but don't just stop, because you're going to wind up knowing less than others about your patient. You never want that to happen.
Do you recommend loss of enjoyment of life index on the first visit?
Well, I'm going to answer that like an attorney, and the first words out of my mouth are going to be, it depends. So it depends, because if the patient was in an accident last night and you're giving this form to the patient, right, the following day, are they going to be able to fill it out completely and accurately? And have they had a chance to figure out what their loss of enjoyment and duties under duress are? And the answer is probably going to be no. And so what happens is the patient gives you back a form that's blank, right? Because none of it applies just yet. And when you get back a blank form, that's problematic. You can't just hide it or make it go away. So my suggestion is wait a few days, or wait 5 to 7 days from the time of the accident, and then give it to the patient. Give them an opportunity to do certain things or find out what the problems and the difficulties are before you give them some of these forms. So this is the nuance of personal injury. These are the clinical judgments you have to make. It's not cookie cutter. Every case is different. So that's a good question.
How far back do you go for previous records? What if they had 3 MVAs and they are over 20 or 30 years old?
Okay, that's a good question too. Normally you go back about 3 years, sometimes 5 years, but you also, when I discussed this earlier about meeting with the attorneys and using it as a little bit of a marketing thing, you can ask the attorney that's sitting across from you, how far back would you like me to go? And every attorney is going to be a little bit different, but the average is about 3 to 5 years.
What is the maximum treatment gap you can justify for a PI case? Many carriers deny treatment after just 2 weeks.
Yeah, that's a good question too. 2 weeks is quite a long time in the PI world. So what I would start to do, my recommendation to clients is pretty much a week or 2 to 3 visits, and then that you either have to contact the patient. I mean, I'm sure you're contacting the patient anyway, but contact a representing attorney, get them involved, because representing attorneys want to know if their client is not compliant. But anything more than a week, and you're really getting out on the thin branches. So 2 weeks, yeah, that's a long time in PI land. Yep.
What are the diagnostic imaging tests you suggest for TBI?
Okay, so there's a few of them, but the one that I like and one that you should consider and look into is called a DTI, D as in David, TI, diffusion tensor imaging, which is a form of an MRI, except they use a little bit different sequence, and it focuses on the white matter, and it can pick up the tracks. Normal MRI and normal CT, if you've been doing PI and you're sending your patient out, or the patient goes to the emergency room and they get MRIs and CTs, the majority of them come back negative because they're not looking at the right tracks that have been injured in a TBI, and so that's why they come back negative. You won't run into that in a DTI because it's actually focusing on the tracks of the diffuse axonal injuries that are the cause of the TBI. So DTI is the one that I like to use as opposed to just regular MRI or CT.
Do you think ligament laxity studies to prove ASOMI are important, or do you prefer MRI or both?
Well, they're different. So an MRI, ligament laxity is extremely important. It's a very high value driver, and it's something that I recommend that you look at on your cases by obviously starting with flexion and extension films and then going from there. You do need software for it, but yeah, it is very important, and it's different than an MRI, so it's kind of depending on what are you looking for. An MRI is probably going to show you more disc and possibly some acute swelling and some other things, but the short and long of it is the ligament laxity is an extremely important value driver, and you should be looking for it on all your cases.
How often should home care be documented in the treatment notes?
Okay, so obviously we've got our first visit, right? So before the patient leaves, and then we pretty much want to do it on every office visit. So we want to reference as the patient complying with their home care on every office visit, and it can just be a quick sentence or two about that. And then clearly, if we're changing it somewhere down the road, for example, we're moving our patient from ice to heat at the appropriate time, we would do that example that I just showed you, where we're doing the type, the frequency, and the duration as well.
Is it better to file with patients' health insurance in which benefits can be verified versus using auto insurance that sometimes fails to disclose coverage?
That's a good question too. Wow, that's got a lot of possibilities. And that's the beauty of personal injury. But okay, so I'm going to stay away from the health insurance, but let me just kind of throw this back to you. You should be able to get, whether your patient, I don't know what state you're in, but where your patient has PIP or MedPay, you should be able to get that information. Now, maybe you can't get it from the carrier, but you should be able to get it from your patient if you have the right policies and procedures in place on the first office visit at the beginning. So not being able to get the patient's auto coverage, that should not be a problem. Once you determine whether they have it or not, then you have to make a decision on living in the third-party world, waiting for settlement, billing health insurance. If there's a representing attorney involved, they may have some input into that. That's a hard question to answer in this setting. So yeah, but that's a good question. But I would get that information from the auto carrier through your patient. That should not be a problem, though.
Okay, I don't
Good
see any
question.
more questions.
Okay. You guys stick around for just a second. I do have a gift for you, and I just wanted to recap. Get more info at the start. Look out for these trauma injuries. These are different, right, than your than your health insurance patients. And appropriate and timely home care are extremely important as well. All of these are critical mistakes that need to be overcome. Now, for those of you that are not familiar with AIIP, the American Institute of Personal Injury Physicians, I just want to quickly tell you a little bit about who we are and what we do, and then I have a gift for you that I think you're going to like. As I mentioned earlier, you know how providers have some difficulty with personal injury, frustrating. There's a lot of different elements, as you can see from all these questions, moving parts, constant changes in requirements and documentation, diagnosis, management, not to even mention any of the attorney or the auto carrier issues and resistance that you can encounter from those entities. Well, at AIIP, we have systemized programs that include not only practical materials, forms, checklists, algorithms, tools, resources, and underlying support that helps providers overcome the obstacles of personal injury. And we target it to get it into your specific practice as opposed to just getting generalized personal injury information. It's pretty much everything you need from the initial incoming phone call from that new PI patient right through care and release, and even beyond as well. And it has an effect of removing confusion and aggravation that so many providers have. It's going to increase your confidence right away. That's the number one thing that providers tell us all the time. It'll protect and strengthen your cases. It'll help and grow and market the PI aspect of your practice. And for those of you that are interested, will increase your revenue and profitability, right? So that's always a good thing. Now, we have a gift, and if you're interested, we have a white paper that we'll be more than happy to send out to you, and it's called How to Improve Your PI Documentation Immediately, Tips for More Confidence, Better Compliance, and Increased Marketability. And all you need to do is just send us an email, info@aiipip.com. In the subject line, just put white paper, and we'll be more than happy to send that out to you, and we can take this a little bit further and improve your documentation. So I want to thank everybody. Christy, I'll let you wrap it up, but I do want to thank everybody for watching. If you do have any questions, you thought of something afterwards, you can certainly email the same info@aiipip.com.
Well, we did have two more questions that came in that I would love for you to address since we have a few more minutes.
Okay.
One of them is, do you know of a book or reference material for Kentucky on no-fault PI cases?
I missed that one word. Do you have a book or reference on what? On PI cases?
Yes, Kentucky no-fault PI cases.
Oh, do I have a book? No, I don't. No fault, though. Kentucky is a PIP state, and so you should have, I believe it's 5,000 PIP that should be available for your patients, and you can get their deck sheet when they come in, and it should be there unless they somehow refused it, but I believe it's 5,000. But if you're having issues getting that, or if you're having issues billing and getting reimbursed, you know, that's a whole nother story. But I believe there is no book per se, but Kentucky should have 5,000 PIP if I'm not mistaken.
And the last was, what can we do to stay more up to date with current PI protocols?
What can you do? Well, take as much PI classes and webinars like this as you can. You know, PI is the, as I mentioned earlier, it's the part of your practice that's changing. The insurance carriers change settlements. Attorneys that you may or may not be dealing with change things up the way they have to settle cases. Certain things become more important, other things become less important over time. Unfortunately, as providers, we don't, if you're not actively pursuing that, by the time you realize it, it's sometimes taken a toll, or it's affected your bottom line, where you might get insurance carrier denials, you may get attorney reductions, you may get cutoffs. Maybe you're in a PIP state where you do have access to a certain amount, but carriers are quickly cutting you off because of your documentation and your management, and you're not keeping up. All of that is costly, and it can actually be overcome by taking proactive steps, taking webinars, taking seminars, studying this part of your practice. This is an extremely lucrative part of your practice, and a lot of providers tell me that PI pays for their practice, where there's the profitable part of their practice, where all the other things maybe cover the overhead, but their profit is in PI. So, this is something that really should be studied and followed up on and kept up on. And that's the way to do it, really.
Well, thank you so much, Dr. Scott. Just want to remind everybody, I just put in the chat box the link to register for next week's webinar with Dr. Jay Greenstein. It is Take Your Practice Mobile to Make Your Impact Global. We are going to have my chiropractor bestie, Dr. Jay Greenstein, here talking about revolutionizing the patient experience. And that means going digital, because let's be honest, TechNet wouldn't be such a popular topic of conversation if everybody wasn't always looking at their phones. So we're going to be talking about how to use mobile apps to create an extraordinary patient experience, maximize their adherence to the care plan, capitalizing on your practice's ability to drive even greater revenue and profit. So make sure you check that out. You can click on that link in the chat box to register for that, or you can go on the website at ChiroHealthUSA.com. You will notice that we do have 2 webinars listed for next week, because we are sponsoring a webinar for the Foundation for Chiropractic Progress. It starts the hour before ours, so you can, if you want to, do 2 webinars back to back, but it's Chiropractic and Addiction Beyond Pain Management with Dr. Kyle Bills. And again, just put the link in there so you can do really quickly, go up, check it out, what it's all about, register for that webinar with the Foundation for Chiropractic Progress. All of our webinars are posted for September and October, so make sure you're registering early. We will have the last 6 of the year, November and December, posted in the next couple of weeks, and I cannot even believe that I am saying that. So everybody, we're going to wrap this one up early, 3 minutes early. I hope you have a fabulous day, a wonderful week, and we'll see you next week. Oh, and I just forgot. A lot of you have been emailing me about certificates of attendance for attending webinars, because you want to track and see what you've been, track what all you've been attending. Now in File Share, you'll look now, you can click Download File under Certificate of Attendance. It'll print it off. It has the date, the topic, the 1-hour webinar, who was the presenter. So those will be a part of every weekly webinar, because last week I sent out 335 certificates of attendance the day of the webinar. I know, aren't y'all impressed? Because I did that in like 2 hours. I'm super impressed. But anyway, I wanted y'all to get off early. So we got a minute, 45 seconds to go. Take a break. Have a fabulous day, a wonderful week, and I'll see you next Tuesday. Bye, everybody.